Thank you, Nilanjan. Setting up a pediatric cardiac airway program. As you know, airway program is usually run as a surgery along with a pediatric cardiac program. And very few centers has a dedicated pediatric airway program integrated into the pediatric cardiac surgical program. Setting up a pediatric cardiac airway program has its issues in the sense that the primary objective, the pediatric cardiac surgeon has to get tuned or get trained in pediatric cardiac airway surgeries. As pediatric cardiac surgeons, we are much more in use in doing surgeries for the heart, the arteries, veins, and the valve. But airway surgeries, we are not much used to it. Traditionally in India, pediatric thoracic surgeons does the thoracic surgery is primarily done by pediatric surgeons, and upper airway surgeries are done by the head and neck surgeons or the ENT surgeons. During our training period, as pediatric cardiac surgeons, you rarely see airway surgeries, and one, it's uncommon, and very few centers which does the training does airway surgeries. And one issue is, as pediatric cardiac surgeons go into the airway surgeries, few issues he faces are, one is there is poor basic training. He is not used to doing airway surgeries. When you do pediatric cardiac airway surgeries, basically the surgeon has to make the decision. You don't get in a situation where they like the cardiac surgery where the pediatric cardiologists investigate and tell you what to do. Here, you may have to make the primary decision, when to intervene, how to intervene. These decisions had to be made by them. And second issue is that the airway surgeries are non-forgiving. If you end up in complication, they are mostly very much devastating, and even they may cause even death. So there is an issue in a pediatric cardiac surgeon venturing into it. But pediatric cardiac surgeons are now called more into doing trachea and airway bronchial surgeries. Why? Because as pediatric cardiac surgeons, you know that in your post-operative status, airway complications are probably the most devastating and probably the most causing the maximum morbidity. And these are one lesion which just stays end on in the ICU, and you continue doing conservative management. And tracheobronchial lesions, most of them are associated with congenital heart defects. So you are forced to do surgeries or interventions in them. And tracheal surgery in children require cardiopulmonary bypass. So again, you will be called into it. And in India, with early detection of congenital heart diseases, with more and more newborn surgeries being done, with sophisticated imaging, more and more airway lesions are coming into the foreway, and the pediatric cardiac surgeons are called into it. So a pediatric cardiac surgeon has to evolve into a pediatric cardiac airway surgeons. How can we do it? It is important in the training period. Airway surgeries are also given importance, and in the training period, you incorporate it in the basic training program. Since these surgeries are rare, as you practice, one thing you can do is to have a combined surgical practices. When there is an surgeries in the upper airway or in the thoracic surgeries, as such, we should rub with them, assist with them, and get acquainted with doing surgeries in the upper airway, the thoracic surgeries, and so that you get more confidence, you understand the technique and venture into complex airway surgeries. As pediatric cardiac surgeons, we are very much in tune in reading how the images of an echocardiography, but we are extremely not at all used in knowing how a pediatric bronchoscopic images read. So as pediatric cardiac surgeon, if you want to evolve into an airway surgery, it's important. It's wonderful if you can do it by yourself, a bronchoscopy, but at least what I would advise is, if a pediatric bronchoscopy is done in the case in your ICU or in any other ICU, you should go in and see the images, get acquainted how a normal pediatric bronchoscopic images see, as well as if there is a lesion, how to identify post-operative when you do again a bronchoscopy, how they see this. You should get used to it. And this is the only way, because you may have to make the primary diagnosis here. You may have to make the decision what to operate, when to operate. Unless you are acquainted with the bronchoscopic images, it will become difficult. So these are the stepping stones. Once you do that, probably you can venture into it. Setting up a pediatric airway surgical program is also like how you set a football team. As you know that in a football, there are 11 people. There are important people in each position. If you have a good football team, you need know that there are specialists at each position and they are able to do their work well. Then only you'll get a good result within the football. Likewise, to have a good airway surgical program, having a good surgeon is not enough. There are other things involved. The essential elements involved, you need a quality infrastructure and equipment and a highly level of skill among caregivers, a coherent team, a very supportive administration with a well-developed referral basis with favorable economics, a system of charitable care and a sustained system of service and a constant focus of quality and improvement. As such, the other important thing is to have adequate resources. Should have adequate infrastructural equipment and disposables, as well as in human resources. With the current status, the material resources are in place, but the most roadblocks are happens to have an adequate human resources. So to have a comprehensive pediatric airway program, you need a 3 branches, mainly the pediatric airway surgical team, a pediatric medical team, as well as an intensive care team. In the pediatric airway surgical team, along with the pediatric cardiac surgeon, you need an anesthesiologist who is in tune with the pediatric airway surgeries, a perfusion technologist, as well as a head and neck and the pediatric surgeons. Pediatric pulmonology, if you have a pediatric pulmonology, it's really a gem, because as you know, once you venture into the airway surgeries, most of the late complications, if you have an interventional pulmonologist, then only you will be able to set in a comprehensive program. Along with the pediatric pulmonologist, you need a critical care pediatric specialist, pediatric radiologist who is in tune with the airway imagings, general pediatrics, and non-invasive imaging modalities. A post-operative intensive care should have an intensivist who is again in tune with the management, a clinical pharmacist, infection control, nursing, intensivist, and nutrition. This is a comprehensive pediatric airway program. As you can see, most of these branches are available within the pediatric cardiac surgical program. So it just needs fine-tuning and certain amount of expertise in certain regions. So if the expertise is available, this is pediatric cardiac surgical program is what I feel in one program where you can set in a comprehensive pediatrical airway program, because most of them are available within a comprehensive pediatric cardiac surgical program. You just need few expertise in certain areas, and then only you will have an adequate human resources. So this is adequate. Having a human resources is probably the roadblock in having a comprehensive pediatric airway program in many of our centers. And at last, a medical social supporting staff unit is also important. Along with it, you just need few specialties. If it's available, you can fine tune those specialties. They will add up to have a comprehensive unit. You need a referring neonatologist, a pediatric surgery, pediatric nutrition, neurology, genetics, a deglutition team, ENT head and neck surgery, and a palliative surgery. Because again, it's a very morbid disease. It have associated defects. So having a other concerned specialty adds up to the team. Now, having an adequate human resources, there are certain things has to be in place. It is very important that each cases in the airway, you bring into a pediatric airway conference. Likewise, where a pediatric cardiac surgery, where each team has weekly cases discussed in a cath conference, it is important that the airway conference is set in and each cases are brought into the conference. The airway conference typically will have a pediatric cardiac surgeon who is trained in the airway surgeries, head and neck surgeon, ENT, pediatric critical care, a pediatric intensivist or an anesthetist and a pediatric cardiology. This is important in the sense that there are few areas where the airway surgery, the decision making is straightforward, but there are a lot of areas where you can either go for a conservative management, which is the easy management, or you have to venture into the surgery. It's not a straightforward decision. Not only that, there are certain areas you don't have an isolated mid-tracheal lesion, very rare. You may have to have a combined help with an upper airway involvement, lower airway involvement. So discussing each case threadbare in a pediatric airway conference is critical to have a good result. Second important thing in venturing into this program is to have a protocol-based management. Because to get a good result in a pediatric airway, you should have a protocol in place. Because as we know, if there is any complications, the results are almost devastating. So it's important to have a protocol based managed. We just cannot bring these children into the ICU and just think that they can be managed by a pediatric cardiac team because they have been doing so with most of the complex cardiac cases. You need a protocol in place for the preoperative management, intraoperative care, post-operative care, as well as a protocol regarding how these children are to be followed up with further scopies or with each specialties. Once these protocols are placed, then probably you can venture into a comprehensive pediatric cardiac surgical program. And another important thing is to have a database, because now pediatric airway surgeries, new techniques are happening, new approaches are coming, and these children after surgery often have a very erratic follow-up, because as you know that there is no dedicated pediatric cardiac airway program available in the country. So once surgery is done, they don't know where to go. They get followed up either with peripheral pediatricians, and they rarely come for follow-up. And variable specialists needs to have a follow-up to know, catch up the results as well as to know the complications. The late complication can set in slowly, and most often you see these children come after surgery very late to you, when you could have done with an early management and save these children. So having a database and having a regularized protocol helps you to know your results, change your results, as well as to have a better results. So finally, the lessons learned in setting up a program is to have a formal training for pediatric cardiac surgeon in airway, which is a starting, setting up a team. You iron out your people who are with you, get them acquainted with the airway, and then you can set in a team. Case discussion, you bring in the cases to an airway conference, make that practice to discuss in group each case threadbare, have a protocol-based management, and have a plan for a very long follow-up, keep them in their database. And finally, you need a very good institutional support, because these are like pediatric cardiac surgeries. These surgeries, sometimes the children can get stuck up in your ICU for very long unless the institution understands this and supports that. The pediatric cardiac airway program may not set in. So these are the final things. Thank you.